talk of today is on H. pylori, and you all know that H. pylori has been with us for so many years, and it's such an important topic for us to discuss and get to know about more. I'll start with some stories of my patients. First one is Mr. J.M. He's completed clarithromycin-based therapy, levofloxacin-based therapy, bismuth-based therapy, and asaferyl-based therapy also. And the guy is stiff worried, you know, the bacteria is not going away. So what should we do? Should we do an endoscopy and then culture the bacteria? And again, another patient, 13-year-old girl, treated twice with clarithromycin-based therapy. She's exhausted all her funds. She stayed with the grandmother who takes care of her. And again, they're really worried because the bacteria is not going away at all. A third patient is completed clarithromycin-based therapy, levofloxacin-based therapy. And again, she's worried that she'll get gastric carcinoma. She's also ready to write a will. So I'm sure all of you encounter the same things in your lives with such patients coming in, day out. They're not getting better with your treatment. Again, another patient, a 54-year-old patient with GERD and also angina. She's not getting better at all. We've tested for H. pylori in Mombasa, and we don't find it, but she goes to India. Somehow they find the H. pylori, and they say, okay, you got H. pylori. She feels better that there is a diagnosis now, at least for her. I'll spend the first half of my talk telling you why we need to treat this bacteria, and tell you in the second half about the treatment options that are available, and then you can make your own choice. So this is a bug which has been carried over for millions of years. In fact, there was an Iceman in Italy who was found, there was a corpse found in Italy some years back, I think 2 years or so back. And this corpse, they found that it had H. pylori in the stomach, and the stomach was actually diseased. So it colonizes the stomach, human stomach, at a very early age, around 18 to 36 months. Sometimes, for some reason, even babies tend to have an H. pylori positive. We don't know why. So a lot of times it's spread by fecal-oral route. And these days it also seems that the mother-to-child transmission at a young age is also very important. So 50% of the world's population do harbor this bacteria, and the prevalence is higher in developing countries compared to the developed countries. Now, what factors does this bacteria have which help it to thrive in our stomachs? One of the important factors is its ability to produce urease. And urease is an enzyme which helps it to maintain a slightly alkaline environment around it. And of course, it has motility and factors, and it can survive in low oxygen status. Again, it has some adhesins which help it to bind to the epithelium of the stomach. And when it binds to the epithelium of the stomach, it evades the immune system, and that leads it to persist in the stomachs for a very long time. So for years, you get the bacteria at an early age, but maybe you're diagnosed at the age of 17 or 18. Again, it has a lot of disease-inducing factors like GAG-A protein, which is a cytotoxic antigen protein, vacuolating cytotoxic protein, and these also help in disease production. It has also a liposaccharide endotoxin, which acts like a slow poison. It's not like in other gram-negative bacteria where you have the endotoxin and you get a reaction, but it results in production of cytotoxins slowly over a period of time, and it tends to help the bacteria in surviving for a longer period. Now, what happens when you get the H. pylori in the stomach? You tend to get initially superficial gastritis, and if this gastritis involves mostly the antrum, then you end up getting more of a ulcer in the duodenum. When you have active gastritis involving the entire stomach, then there is an increased risk of getting the ulcer in the stomach. When you have chronic atrophic pangastritis, there is an increased risk of cancer. Now, when you have the gastritis, you can have no symptoms at all. The patient can just harbor the bacteria without any symptoms. You can get peptic ulcer disease. You can get patients getting dyspepsia, dyspeptic symptoms. You can also get persistent achlorhydria, and you can also get these extra gastric diseases like immune thrombocytopenic purpura. It has been associated with cardiovascular diseases and various other conditions. But the thing that scares us most is the fact that it is associated with causing adenocarcinoma and mild lymphomas. So it has been classified as a carcinogen by the World Health Organization. It's a class 1 carcinogen. And as you are all aware that there has been a lot of gastric cancer in areas around Japan, and that's where a lot of this H. pylori has been studied. Now there are various strains of H. pylori. There are the CAG-A positive and CAG-A negative strains, and the WAC-A positive and WAC-A negative strains, but the CAG-A and the WAC-A strains seem to be associated more with the gastric cancer compared to the negative ones, though even the negative ones can cause cancer. Now, there was one meta-analysis in which they found that when they eradicated H. pylori, there was a reduction in the gastric cancer by around 44%. And the number needed to treat would be 124 to prevent one gastric cancer. Etiology of gastric cancer is complex and it's multifactorial. So you need the H. pylori, yes, but you also need other sort of factors like genetic factors plus lifestyle factors to result in the malignancy. Now what happens in our daily practice is the moment a patient will come that have Googled H. pylori and they know it causes cancer. And maybe his H. pylori is not getting treated, so they get worried stiff. So you need to explain to your patient and at least tell them that there are many factors which do cause the cancer. It's not only the H. pylori alone. Again, this was a prospective study of around 7 to 8 years done in Japan, whereby they looked at H. pylori positive and the negative people, and you can see the graph. It's separating quite early. In fact, they had to stop this study and make sure that everybody with H. pylori got treated. Okay, again, as I mentioned, how it causes malignancy is there are multiple factors. It has the H virulence factors itself. There are the host factors, and there's the environmental factors like taking a high salt diet, smoking, using some foods with carcinogens. And when you get all this, you end up getting a gastritis, which can later result into intestinal metaplasia, and then which can go on to form intraepithelial neoplasia. That's sometimes you can get patients at an early stage and treat them, or you end up getting gastric carcinoma. Now, I'll not go a lot into the diagnosis because this will be dealt with in the next talk. Diagnostic tests are divided into endoscopic tests and the non-endoscopic, non-invasive tests. Endoscopic tests, you have the rapid urease test. You have the histology-based testing. You take the biopsy and this will be reported. The new kid on the block in testing is the molecular PCR. It's been there for many years, quite a few years, but more recently it's been tested and it's also available here in Kenya. The good thing about this test is it can tell you about clarithromycin and levofloxacin-based resistance based on the biopsy. And of course, biopsy and culture sensitivity. Again, biopsy and culture sensitivity of H. pylori is very difficult because there's a stringent protocol which has to be followed. The specimen has to be transported within a certain amount of time and the growth is also quite difficult. Now, the non-invasive tests which we use to test and treat are the H. pylori stool antigen test, which we use commonly over here. There is the urea breath test and the serology. In setups like ours, where the H. pylori prevalence is so high, and in urban settings where everybody is dished out with this bacteria, with antibiotics. This test doesn't hold. You shouldn't use the serology test because it can persist in the blood for long periods, maybe 2 to 3 years after treatment. So the best test to use would be the stool antigen test if you are going to use the strategy of test and treat. Now, which patients to treat? Patients who have ulcer disease, patients with dyspepsia, patients with early gastric cancer, iron deficiency anemia. If you are planning to put your patients on long-term non-steroidals, a combination of non-steroidals and H. pylori can result in ulcers which can really bleed. So it's better to eradicate your H. pylori if you're planning to put your patients on non-steroidals. Again, patients who are asymptomatic, where there is a high prevalence of malignancies, gastric malignancies, those are the guys you want to treat. And of course, the patient's choice. If they want to be treated, then you better treat them. I'll now talk about the treatment of H. pylori and what tools we have. We like to all give our Smarties to the patients, write for them, a big list of drugs which happens with H. pylori treatments. The latest treatments guidelines are from the American Gastroenterology Association and the Toronto Consensus. Now, the first line of treatment which we all use is clarithromycin-based therapy. You're all aware of the kits that we get over here. There are various kits going on in the market, and we dish them out for 2 weeks. You can use clarithromycin-based therapy or metronidazole-based therapy twice a day for 2 weeks. You can also use the drugs alone, a PPI, clarithromycin amoxicillin, or a PPI metronidazole amoxicillin for 2 weeks. Then you have the concomitant therapy. The concomitant therapy does also give you quite a good eradication rate of around 80% or so. And this involves using 4 drugs together twice a day for 2 weeks. You can see the number of drugs really goes up when you're using concomitant therapy. Again, another recommended therapy as a first line is a sequential therapy, whereby you use PPI and amoxil initially for the first 1 week. And the basis of using the PPI and amoxil twice a day for 1 week is that first you get rid of the burden of the bacteria in the stomach. When you get rid of a large burden of the bacteria, thereafter you continue with your PPI, clarithromycin, the metronidazole for 1 more week. Again, on the same line, you have the hybrid therapy. In the hybrid therapy, you use the PPI and the amoxil for 2 weeks, and in the second week of treatment, you introduce your clarithromycin and metronidazole, which also gives you a good cure rate of around 80%. Now, bismuth-based therapy, which does not use clarithromycin or amoxil, can be used, and this is again for 14 days. The recommended PPIs for treating H. pylori is esomeprazole or rabeprazole. Now, we all treat H. pylori, yeah? We all enjoy writing the drugs, but honestly, ask yourself, if you give how many of you finish a course of 5-day antibiotic? I'm sure, we don't finish, us as doctors, we don't finish a 5-day course. Now you're giving a patient such a hefty dose of polypharmacy, how do you expect them to finish? And I think that's where things go wrong, when we don't explain to them, because they end up not complying with therapy because of the number of days of therapy. Maybe sometimes we don't talk to them about the side effects, what they're going to experience when they're going to take this treatment, and again they don't take the medication. Again, other issues that do come up in our setup are maybe suboptimal, standard drugs. We have a lot of PPIs in the market. We don't know how they work, because you need to get your gastric acidity to a low level to reduce your acidity before your antibiotics are going to work. All right. Then if you have high bacterial load, but one of the biggest things, major things, is antimicrobial resistance. And this is the main thing which is coming up in the treatment of H. pylori. And maybe that's why patients come again and again not having been treated by this. Now, there has been a lot of, if you Google on H. pylori in Kenya, you'll get a lot of studies done on H. pylori. But we have very little data on sensitivity of this H. pylori to the drugs that we use. And I think we need more studies to be done on H. pylori sensitivity in our region in Kenya, especially by the postgraduate students or the young, guys who are planning to do M.Med. This would be a very good field to do your study on. Now, we have Western data on H. pylori resistance, We have data from Europe says there's a resistance of around 28% to clarithromycin, 20% to levofloxacin, metronidazole around 46%. However, amoxil has a very, very low resistance. Now, this resistance is important because these are the backbone of the treatments that we use, so we need to know the resistance in our area. Now, assuming that you had a very sensitive bug which was sensitive to clarithromycin, all right, and it had 0% resistance, then your eradication rate would be 95%. But you come up with 100% resistant bug and your eradication rate goes down to only 15%. So that's very important for us to know. Now, let's say if you knew if in our setup we knew the resistance, then the guidelines recommend that if we know that our bug is sensitive, then you are good to go with the clarithromycin-based therapy, and or the metronidazole-based therapy. If this one fails, then you can go to the levofloxacin-based therapy and then to the bismuth-based therapy. But if you don't know the resistant pattern in your area, then it's recommended maybe we should be using 4 drugs, the concomitant treatment, that is the amoxil, metronidazole, clarithromycin. And of course, if this fails, you go on to the levofloxacin, and then you go on to the bismuth-based therapy. Now, what will be your salvage therapy? Let's say you use a clarithromycin-based triple therapy for 2 weeks, and the patient did not do well. Then you don't need to repeat the same drug again. But however, in practice, we find that happening every time. A patient has used the drugs twice or thrice and before they get to us. So a bismuth-based therapy can be used as a salvage therapy for 14 days. We have bismuth-based therapies available here. Again, you could use your levofloxacin-based therapy for 14 days if it has not been used. You can use your concomitant-based treatment for 14 days. Again, there are some studies which have used high-dose PPI and high-dose amoxicillin for 2 weeks, and it has resulted in eradication of the H. pylori. There's also the rifabutin-based therapies, unfortunately, which is not available in our market. So we have heard so many things about the H. pylori, and we know that it stayed with us for a long time, many, many years. But is there any good? Does it confer any benefit? And there seems to be some inverse relationship between H. pylori and asthma in children under 5. So where you have high prevalence of H. pylori, the asthma tends to go down. Relationship of GERD and H. pylori, when it seems like you have high H. pylori prevalence, the GERD, gastroesophageal reflux disease, is less. And we don't know still if it has some immunomodulator properties which will protect us from certain diseases. So in summary, it's important to know that H. pylori is a pathogen that induces chronic gastritis, and it can result in a spectrum of diseases. I think before you start your patient on treatment, you need to talk to them about the compliance, what they are going to experience during the treatment, and side effects, and maybe resistance-based therapy would be a solution to eradication of this bacteria. Thank you very much.
My question is, 5 or 3 years ago, we used to be told that the oral cavity was acting as a reservoir for the H. pylori. And actually, they quoted a percentage of almost 50 to 78% of this bacteria was found in the periodontal. Now, is this the barrier where we forget to treat the dental part and patients always come with recurrent H. pylori infection through the gastric?
H. pylori in the oral cavity, honestly, I have not come across any studies which say that. Sometimes we do biopsies of the duodenum also, and once in a while we do get H. pylori. But we know that this bacterium loves the stomach, it loves to hide under the acid. So that's a very important point, that it likes the stomach.
Thank you for the wonderful presentations. One question for Dr. Firoz. The sequential and hybrid therapies, won't it be fostering resistance to the H. pylori when we use 2 medicines, a PPN and amoxicillin, for 1 week and then go to the other one?
Now, about sequential therapy and hybrid therapy and it giving resistance, one of the things we know that there is very low resistance to amoxicillin, only around 1% or so. And currently, in fact, there have been studies in France where they've used higher doses of amoxicillin, because even the 1 gram twice a day, seems to be not completely optimal. So they've used TDS doses, and they've found to eradicate the bacterium fast, to reduce the burden. And once you reduce the burden, then your clarithromycins and metronidazoles do work well. Eradication rates of around 80%, equal to when you're giving concomitant therapy, have been found in trials.
Thank you for the presentations. My question is directed to Dr. Firoz. Is there a role of use of probiotics with the different therapies for H. pylori? Thank you.
The question on use of probiotics, there's been a lot of, the probiotic guys are advocating that for H. pylori you use them. Yeah, sometimes probiotics help in reducing the symptoms of diarrhea, abdominal discomfort. But actually in the treatment of H. pylori, there have been a few studies which have come up, but I think we'll need to wait for more studies about the use of probiotics in treatment of H.